64-year-old male residing in Chennai came with the complaints of frequency of micturition, daytime frequency 8 to 10, nocturia 3 to 4 times, associated with the intermittent urgency. There are no obstructive urinary complaints. There is no history of dysuria, hematuria, lithuria, no history of fever, abdominal pain, loss of weight or appetite, no history of prior intervention, no history of any bowel complaints or backache. Patient known hypertensive. There is no previous surgical history. Patient is known smoker, one packet per day since 25 to 30 years. Family history, mother having CA colon. Patient is on antihypertensive tablet amlodipine 5 mg OD per day. No history of any allergy.
Let's stop here. The first page, first slide. Yeah. Okay. So we are not dealing with a practically healthy man, right? Except for the hypertension, he has got no problem. Okay.
Yes, sir.
So his presenting complaint was what? Frequency, right?
Yes.
And, I would rather say that rather than you complain of frequency of micturition, you can actually start with, because usually, see, in daily day-to-day, patient is primarily disturbed by the nocturia. So nocturia was the primary thing which must have brought him to the hospital or to the doctor, right? So because you see, we have been taught that the history, everything should be given in the patient's own version. So presenting complaints means what brought the patient to the hospital. So in your case, I am very sure that the patient, if it was only daytime frequency, would not have come to you. He would have come to you because of the nocturia. So let us talk about this frequency and nocturia thing. So when you are sitting in OPD, I think is the best place to learn. So this man comes and just tells you only one thing, that I have to get up 3 to 4 times at night. What more question you are going to ask?
Sir, I would like to ask him whether it's a bothersome or not.
No,
Then I would like to ask him any associated cardiac history, cardiac medication, whether he is taking or not. Whether he is taking a fluid before sleeping, that I would like to take history. Then I would like to go into the severity of the patient by taking IPSS score. I would like to.
Yeah, those questions you asked, that there was some urgency, flow was okay, everything. So let's assume every other thing is negative. Only problem is nocturia. So you said that the additional thing about nocturia, I will ask for the medications, water intake, and cardiac problems, right? You see, in very important thing, especially at this age group, you should always take history of his sleep habits.
Okay, sir.
Understand? Sleep apnea, snoring, these are the important reasons. You see, what happens is a patient will tell you that he has to get up 3 4 times and pass urine. Now you can interpret it in different way also. Whether the patient is being woken up by the urine, or patient was woken up and hence he passed urine. There is a difference. You understand? Anybody who gets up at night or his sleep gets little more shallow, he becomes aware of bladder and then he has to pass urine. Even a normal person, actually. If I give you a call at 2 o'clock say at the night, you get up and then you become aware, you go and pass urine. So you pass urine because you were awake. This is in real life. This is the main, this is very important thing. If anybody gets up at say 3 4 times at night, always look for his sleeping history.
Yes.
Okay, so that is very important part. And I think, what about daytime frequency? Daytime frequency again is a very important thing. Besides, the disease you have asked for, urgency and all that, water intake is a very important thing. There are many people who start their morning with a liter of water. You have to take that part into consideration, whether they are over drinkers, because this is a fashion also, and people are. You see, I have got patients who come to me, Doctor Sahab, urine pila aata hai. So they keep drinking water to keep it clear. So they have got frequency. These are the things in your practical life. It will be very important, especially even in examination. You should say this, that you will elicit the history of his sleep habits, especially sleep apnea, which is a very common thing. Okay, chalo. Let's move ahead.
Okay. Over this much. This is the history. Should I go ahead?
Yes. By the way, is there any mention of normal frequency? What is normal frequency? What do you call increased frequency, and what do you call it normal frequency? In the books,
So
is that
normal frequencies are 3 to 4 times a day.
okay?
That is a normal frequency of urination.
And night time?
So night time, one time is okay. More than one time, that is nocturia, preceded and followed by the sleep. Then it is called nocturia.
So another way of eliciting history in your practice, rather than saying that he is passing urine 6 to 8 or 8 to 10 times a day, you should ask how many hourly he passes urine. You see, there are many patients who will pass 6, 7 times by 12 o'clock, and after that they are normal. Then the interval increases. It can be vice versa. There are many times people say that they are fine till about 2 o'clock or 3 o'clock. Then in evening they start feeling more and more frequency. So it is a very good idea, not for the examination, but in your practical life, that the way to ask history of frequency is hourly. So once you pass urine, how many hours later you pass the second time? So usual interval is 3 hourly, 4 hourly, which is good. But if patient says that I pass urine every hour, then you start thinking in terms of disease, or you start thinking in terms of increased water intake, which is a common problem.
Okay, sir.
Yeah, next.
Sir, should I go ahead? General examination, sir.
Absolutely.
Patient build is average, sir. Performance status is good. Vitals are normal. On general examination, there is no pallor, icterus, edema, lymphadenopathy, or cyanosis. Back and the spine both are normal. Per abdomen, on systemic examination, per abdomen soft, non-tender, no organomegaly. External genitalia normal, circumcised. On digital rectal examination, 1 centimeter hard nodule palpable in the left lobe. Grade 2 enlargement. Rectal mucosa is free. Bulbocavernous reflex is positive. Anal tone is normal.
How do you do rectal examination? In what position? Again, not important for examination, but important practically.
Sir, left lateral position we can do, or either a lithotomy position also we can do, or either in standing position also. But left lateral position will be the good preferable.
Yeah, rest of the things are standing and lithotomy and knee elbow. They are all theoretical. You see, they're very uncomfortable to do and all that. But now I'll tell you another thing. Normally, when you do rectal examination, this is what have been taught in surgery classes. You know, when you are doing MS, everybody teaches you when the patient faces away from you, right? So that kind of rectal examination actually is good for anal pathologies. Because you see, when you are seeing the prostate, you have to feel it with your palm of fingers, and in that position, it is away from you. Prostate is away from you. Okay, so that position is basically to see the all over anal canal for fissure, for piles, and for everything, including prostate. Primarily for prostate, when I am telling you, just try it once. Let the patient face you. That means right lateral position. So that when you do, your feeling will be better actually. You try this, and I'm very sure that you will not do any other way.
Okay, sir.
See, this is called ULOT, learning from others' experiences. I have been doing it for I think 30 years this way only. Somehow I discovered, and then I've been doing this, and whomever told you, I mean, told this kind of DRE, he has never changed. Of course, for biopsy and everything, left lateral is fine. But for feeling prostate, try this. It is a very good method. It is more comfortable. You don't have to twist and turn and all those kind of things, and your tactile ability improves with this. So when finger is like this, tactile ability is reduced. When finger is like this, you feel better. Try you try it in your practice later on.
Yes, sir.
Rest everything is fine. I mean, another thing we do is that rather than telling you the grade 1 or grade 2 and all those kind of things, we s- we say only two or three things. One, that prostate is in grams. When you do rectal examination, you make a rough assessment that this prostate will be around 25, 35, 40, 50. You can really be quite close to the real weight with little experience. Keep doing it, see the ultrasound, see the TURP or whatever, when you can easily make assessment, make a guess about the weight. So what we say is, when we write on our case, our OPD card, we do rectal examination, you write 35 gram benign. Okay. So when you describe in urology, because now we are not a surgery student, we describe it this way, that prostate is clinically benign or clinically malignant, or nodule is there and all that, and approximate size is 35, 45, 50 grams. Okay.
Yes, sir. Next, sir.
Hmm.
Sir, investigation, sir. Urine routine microscopy. Color is pale yellow. Appearance is clear. pH is 5. Uh, Albumin sugar nil. WBC occasional. No RBC, no bacteria. Blood investigations. Hemoglobin 13.2. WBC 5200. Platelet counts 3,55,000, RBC 107 milligram percentage, blood urea 31, serum creat 1.1, PSA 14.6 nanogram per ml. Should I go ahead, sir?
This is okay.
Sir.
So
This,
whenever I am telling you something, and if you think that there may be another point of view, please come up, ask questions, huh?
yeah, sir.
Ask questions or clarifications. Everything is fine. Yes.
This is a patient uroflowmetry showing around intermittent pattern, which is suggestive of bladder, bladder outlet obstruction with a maximum flow rate of 16, voided volume 280.
Why do you need this as option?
Sir, it is having intermittent pattern, sir. That may
Explain it further, please. Intermittent is what?
intermittent flow pattern, sir.
Because you see a peak and then there is a downfall, and then again it continues.
Yeah, yes, sir.
You see, intermittent pattern, I don't know whether you have been taught this way, because yes, since wherever you are doing your residency, their teachers may be showing, I mean, telling you this way. Only thing is, see, whenever you see a Euroflow, you should see few things. Number one, that how much is the sustained contraction of the bladder. If you see this Euroflow, the contraction is sustained, right? That means the graph is not touching the baseline or close to the baseline. Okay. And another good thing in this graph is the flow stops. It is not, keep trickling for a long, long time, because trickling graph increases the rather decreases the average flow time, right? Average flow time. So I would rather say, you see, you should not really read the Euroflow very minutely. His peak flow is, see, you can imagine this patient is voiding, starting, going to the peak, and except for one fast dip, you can ignore that dip. So it is something like lazy inverted bell. It is not a classical inverted bell, but it is little this kind of inverted bell. So don't condemn this man for as an obstruction. See, in your history, patient has no complaints. That is very important. You should know one thing, that there is not a great correlation between patient symptoms and the Euroflow graph. You will find many patients who will say that मेरे को पेशाब अच्छे से नहीं आता, and you find good Euroflow, and vice versa. There are patients who says कि मेरे को तो बहुत अच्छा सा पेशाब आता है, and you see बेकार Euroflow. So the thing is, there are so many. I mean, we should have a separate class only on Euroflow someday, or we can do that. I mean, short class, maybe half an hour or so. So many things to learn about Euroflow. Euroflow tells you everything. And so, what do you see? One is sustained contraction, peaks and pattern. You should see the terminal dribbling, what we call. You should see this, whether the graph touches baseline or not. So don't call it intermittent. I would say this is a normal flow, because what you are seeing in this man is only one episode of his voiding, which is not in a natural condition. So we should not be reading this kind of graph with so much criticism. Consider patient is happy passing urine. That's it. And this graph is that supports also. So you can say that this graph is non-obstructive. Okay.
Okay. This is a ultrasound of the right kidney showing normal parenchyma, normal hilum. There is no evidence of any hydronephrosis.
So you are good at reading ultrasound pictures,
Not
or you read?
like radiologist, but okay, sir.
No. When patient shows you ultrasound, what do you see? The report or the pictures?
Sir, like little bit films also, and then report for learning.
Yeah. So can you show me where is the cortex, where is the medulla, and yeah,
Sir, yeah. This is a cortex, sir.
This is the renal outline.
Yeah. This is a cortex. This is a renal capsule.
Yeah.
This is a hilum. This is hyperechoic area hilum.
Why it is hyperechoic?
Hello, sir.
Why it is hyperechoic?
It is because of fat is there.
Fat, sir.
Renal sinus fat is there.
That's good. So that is very important. So when you see the hydronephrosis, where do you see it first?
We are seen at the hilum pelvis.
Pelvis, sir.
So the first sign of hydronephrosis is what they call it splitting of sinus echoes. You see black spots within the white hilum, right?
Yes, sir.
So that is not this one. No, this is medulla. And
Okay,
these
this is
are
medulla.
as well. It is within the white area. You can just move your cursor in the white area. Yeah, so from cranial end to caudal end, anywhere you will find black, exactly like this, which you have mentioned first. Yeah, exactly like this, but in the center of the hilum. This is the first sign, because pelvis is there. First change is the fullness of pelvis. Pelvis is in the center. So you should see the pictures always, So with time, because there are many times I've seen a few times, not many times, that there is a discord between the written report and the pictures. So when I tell them to review the pictures, then they correct their report. Because sometimes what happens is the radiologist doesn't type the report. The typist can make mistakes sometimes. Chalo.
This is the left kidney, sir. Image showing no normal parenchyma, normal hilum, no other significant hydronephrosis is there. Some cystic area, we can see this.
Okay.
like 2-3 cyst we can see.
What are the criteria of simple cyst? I know we are discussing with CA prostate. I mean, we'll reach there. Don't worry. So, what are the ultrasound criteria for simple cyst?
Yep.
It is a cyst.
Like
It is black.
a black hypoechoic black color
Yeah, but
lesion with a well circumcised wall.
yeah. See, there is always a posterior shadowing. The posterior wall of the cyst, they always give a shadow. You go when you go home and when you finish with this, see if you see a textbook of radiology. You must read textbook of radiology. You know Polak and all. Do you read that?
No, sir.
Polak.
Okay.
Very, very good book. I mean, you are in final year, maybe preparing for practicals and all. But first year, second years, you should read radiology book. And radiology book not only tells you the ultrasound picture, it gives you theory and background also. You must read it. I tell my students to go and read. I think my students all read a lot of Polak. Initially, there was a different kind of series. It was a three-part book. Now it is, I think, two-part book maybe, or maybe three. It is a very good book. So all these signs you should know. You should see the picture and you should know that this is simple cyst. And of course, we are not discussing further on the cyst part, but one criteria, most important criteria is that the posterior wall, the wall away from the probe, shows a shadowing. Hmm? Hello?
Is a transverse image of the prostate and uh, hello.
Yeah.
Yeah, sir. This is a prostate area, sir, showing with some amount of bladder and urine is present in the bladder. This is a transverse image of the prostate with measurement we have to take, sir. Like on this screen, we can't able to measure.
Go
We
on, go
have to
on.
take software.
Yeah.
So a report showing right kidney, some few cortical cysts are there with the largest measuring 18 mm lower pole. Left kidney, a normal position size with a cortical echoes with a few cortical cysts, largest measuring 19 mm upper pole. Bladder normal in contour with a normal wall thickness. Prostate is enlarged 4.1 into 4.2 into 5.8 centimeter, around 54 cc. Post-voidal residual urine is 136 ml.
Okay, with such a good flow, we don't expect so much residual urine. Why? Okay, can you make a guess why it is there? Why the residual urine is so high?
Sir,
Is it pathology?
pathology, sir.
Is it pathological?
Yes, sir. So, first of all, it can be, sir, presence of vesical calculus, sir. It can be bladder outlet obstruction, or it can be like neuro.
Oh, don't worry. See, what
Or
now?
CA prostate.
Now, what you are trying to speak out is the theory which you have read, the causes of residual urine, right? So that thing is disconnected from this case. Like neurogenic bladder, in this particular case, now we have got a Euroflow.
Yeah.
Euroflow always tells you that there is something wrong with the nervous system. With this kind of Euroflow, there is nothing. So that thing is out. See, practically speaking, more often what happens is when a patient goes to ultrasound, they ask you to to drink a lot of water to fill the bladder. So they end up filling too much of bladder, right? And you know that when the bladder is overstressed, then bladder doesn't empty itself. You know why? One important cause of retention is over distension of bladder. In cold, in cold, or people who drink a lot and then they don't pass urine, the bladder becomes over distended, and when they finally go to pass urine, it doesn't come out. Have you ever faced this? Have you heard this?
Uh,
Overstretching,
yeah,
overstretching
sometime.
leading to retention, overfilling of bladder, it leads to retention. Have you heard of it? Yes or no?
Yes, sir.
Yes, sir, heard. But
So what happens is there is something called Laplace's law of muscles. So when the muscle, you see, muscle is, you stretch it, say for this extent, it when it contracts, it increases pressure. But when it reaches stretch beyond its limit, then it becomes weak. Okay. So this is what happens when the bladder is over full, patient can have residual urine because an overstretched bladder, it doesn't empty completely. So in these cases, when you are when it doesn't make sense with such a good flow, why should he have this much residual urine? Just repeat it on natural desire. Okay, it's very important to tell the patient that Euroflow and ultrasound both should be done at natural filling of bladder, not unnatural filling. You must remember this in your practice. We see day in day out that patient has been advised surgery. We just repeat it. I've seen 300 ml residual urine coming to zero. I mean, absolutely zero, nil. And you will find it in your practice. Then also you will find that many, if you ask in your history, how is your first morning urine? All right. In the patient 60s and plus, 60s and above, they usually say that first morning urine is difficult because when they sleep well, the morning in the morning bladder is over distended. They take little more time. It comes little more slowly. And sometimes there are patients who say that they have to pass urine 2 or 3 times in morning. By the time, then only they feel satisfied. So this kind of residual urine should not be taken as pathological. So the most likely explanation of residual urine is this in this particular case. Other causes, I mean, whatever you said, they are all theory. No, they are not wrong causes. But if the question is what are the causes of residual urine, then you are right. But in this particular thing, this is situational. Huh? Next.
sir, multiparametric MRI, sir.
Hmm.
Uh, this is multiparametric image of the prostate showing the various phases. The image A shows which is a T2 weighted image showing low signal intensity lesion in a left lobe peripheral zone. This is, sir.
Yeah, you are making a circle around it. Fine.
And so B, I don't know exactly, but D is, I think, C and D both are
The C and D must be
diffusion weighted image.
contrast. C and D must be contrast.
C and D diffusion weighted image, sir.
Okay.
Because it shows enhancement.
D doesn't look like, but fine. I mean, I accept that I'm not great at MRI because I don't have to, but you should be. You should go to MRI department and talk to, I mean, learn few MRIs of different cases, different types. They will tell you better. Obviously, the PIRATE scoring can be done in two ways. One is T2 weighted image according to T2 weighted image, another is DWI. So both need to be known. Okay.
Yes, sir. Sir, report prostate appears moderately enlarged in size and measures 53 into 38 into 47 mm, around 47 cc. It shows 3 into 5 into 8 millimeter of cube small focal low signal intensity lesion at the mid prostate peripheral zone at the 4 and 5 o'clock position. Then in AEF image, then diffusion weighted image shows no focal low signals on apparent diffusion coefficient map and the focal high signal intensity. Then diffusion coefficient diffusion MRI shows a marked early focal enhancement D phase. The periods category 4, there is seminal vesicle and neurovascular bundles are normal, no pelvic lymphadenopathy.
And bones are visible bones.
So this much only there, sir.
And another question which just came in my mind, we were at the ultrasound. Is there any role of truss in routine investigation?
Yes, sir. Truss we can use for to know the proper prostate size. We can use it for prostate biopsy.
No, biopsy, of course, we are doing it. When we do biopsy, we do truss. But before that, you started with ultrasound, then MRI. Is there any, when you order ultrasound for KUB, and when you have already done DRE, you suspect there is malignancy. So at the time of ordering ultrasound, do you order truss also or not?
Sir,
Will
since
you do?
clinically there is a, it's look like a CA prostate hard nodule was there. So I will, with the truss, I would like to confirm the presence of hypoechoic lesion to confirm the hard nodule or presence of like CA malignant lesion, and also to confirm the accurate size of the prostate.
So that means patient has to undergo a painful procedure called truss. You know, truss is very painful.
Yes, sir.
And second time for biopsy. So the idea of asking is, you will not go for truss as a screening for prostate or learning about prostate for size, because size is not a very big issue. Whatever size you get on abdominal ultrasound, the size is not going to change anything, right? If it was 45, it was 35 or 55, doesn't matter actually. So truss should not be, truss is not a kind of routine investigation for prostate. Truss will be used only for biopsy. I'm sure this must be in books.
Yes, sir.
So do not, because I'm telling you this because I see people coming with the ultrasound and truss ultrasound. So, I mean, it was unnecessary wastage of money and it is painful. Because many a times patient, they ask, when you come in practice, there will be some patient who say, trust mat karwana, you know. So, okay. So that was one very important point. You have not included trust in your presentation, which is right. Okay, in your practice also, unless there is real big reason for, say, like abscesses, you are suspecting acute prostatitis and abscess, maybe then only, but this is a different scenario. Huh? Okay, go ahead.
Sir, truss biopsy, systematic 12 core with a targeted 3 core biopsy was taken. Histopath report showing.
Do you do biopsy yourself?
Hello?
Do you do truss biopsy yourself? I mean, are you trained in?
No, sir. No. Here, radiologists are doing, sir.
Okay. And if patient comes to you, have you ever done finger guided biopsy?
No, sir. Here, like biopsy, like we are not doing. PGs are not doing.
So I think you should do something about it. Number one, you should go there and see. So when you keep going there, whenever there is a biopsy, after a few cases, maybe your radiologist allows you to do 1 or 2, because you have to show your own interest first. Then only they will give you. Don't go that, you know, I will go only when they give. That will not happen. You keep going, finally they'll give you. That is one thing. Secondly, it is very important in routine practice. So there are many patients who have stony, hard, frankly malignant prostate. There are many times you see in OPD practice. So whenever you have a really palpable bilateral stony heart disease, what I see many doctors, many urologists, still they are going for trust. You don't need trust for those for two
Yes.
reasons. One, you don't need 12 biopsies. Or maybe two or three or four biopsy, two from each side will be positive. So those are the cases you should really practice finger guided normal biopsy. It is easy to help your seniors. You must learn this also. Okay?
Yes, sir.
Chalo.
Histopath showing type acinar adenocarcinoma, target and left lobe, grade 4+3, ISUP grade group 3, total number of core positive 6 out of 15, percentage of tumor in core 40%, PNI present, prostatic intraepithelial neoplasia present, seminal vesicle and periprostatic fat invasion absent, right lobe is negative for the tumor.
Biopsy, did they really? Because, unless you take biopsy from seminogical, you don't see it. So that's okay, fine. Move on, move on.
Bone scan normal, no skeletal metastasis.
Okay.
This much.
So let's sum up in two, 3 lines.
Uh, this is a 64-year-old male with irritative LUTs, came with the irritative LUTs, having a known hypertension. On examination with a PR suggestive of hard nodule, mostly this is a
Basically, we are working with the patient biopsy proven cancer prostate.
yeah, biopsy prone CF. Yes.
Now, what are the okay? What is your next plan? What comes in your mind? What to do now?
Since as per ISUP grade 3 and PSA is 14, I would like to stratify risk stratification. I would like to do. So this is a mostly intermediate risk group. I would like to counsel the patients and relative regarding the various treatment option available for this intermediate risk.
What
I
are
would
they?
like to first is radical prostatectomy and radiotherapy.
Mhm.
Yes, sir.
You will not mention hormone therapy. You will not mention any other thing.
Uh, yes, sir. Then radical prostatectomy, radiotherapy, and another option is like radiotherapy plus ADT also we can try.
You see, don't worry. When I ask questions, doesn't mean don't get embarrassed or don't feel disturbed that way. I mean, simply we are discussing. There are we have to develop thinking, which will happen with time. It doesn't happen this way. During DNB and MCS, student life में नहीं होता है. We are still learning, especially communicating with the patient is a different art. You keep learning it. So if you think this way, that there are two kinds of treatment. One is curative, another is for control, right? So in this particular patient, our intention should be cure.
Yes, sir.
There are
Yes,
only
sir.
two ways by which we can cure the disease. One, surgery, two, radiation. And this is what you are actually going to tell. Other options like hormone therapy are basically for control and which are reserved for those who are not fit for this kind of treatment.
Yes, sir.
You will tell the patient you are a fit person, you are performance score high, you are young and long life ahead, plus the disease is 4+3, you said?
Yes, sir.
So
Yes.
disease is relatively aggressive, so you deserve a cure from this disease. Okay, then you proceed for surgery and all that. Otherwise, theoretically, what other options? Say, if your exam, you are given this question that treatment for localized prostate. That's it. Describe the treatment of localized
Sir,
cancer.
another like focal therapy options are available, sir.
Hmm.
Like cryotherapy, HIFU, these are options available. Focal therapy.
Okay. So this is all depend on the performance or when comorbidity, life expectancies, right? Okay. So what is your choice?
Since the patient, considering his age and his performance status, sir, I would like to counsel the patient for a radical surgical intervention, like a radical prostatectomy.
Hmm. Obviously, the
And
question is very clear that you are going to do it robotically if you have robot.
yeah, so we have a robot, but not much we are using.
Yeah, of course, everywhere is the same, except for centers, everywhere it is the same. Especially in Corona time, it is totally gone.
Yes,
So,
sir.
okay, what do you do in radical? What What about lymph nodes? How many lymph nodes? Do you do lymph node dissection in this case?
Yes, sir. I will definitely will go for lymph node dissection.
I'm not asking for the surgical steps and all that. Okay, so you all know it, but lymph node, there are certain decisions, lymph nodes. So how much lymph nodes or what is the extent of lymph node dissection in this?
Sir, extended lymph nodes like both iliac lymph node, internal, external iliac lymph nodes, and obturator lymph nodes, sir, I would like to do in lymphadenopathy, lymph node dissection.
Okay, you
I
didn't
could,
you didn't mention brachytherapy.
what, sir?
Brachytherapy in radiotherapy.
Yeah, brachytherapy is also option. Yeah. Yeah.
But brachytherapy used to be a very popular thing in India. They were, I think, only one place they used to do it in Madras. Madras Apollo, I think, had. Usually, nowhere else brachytherapy was available. In India, of course, it is not very popular, but in Europe, it was very popular. I don't know what now, because new techniques of IMRT, IGRT, they have come up. So maybe brachytherapy is going down in those places also.
Okay, sir.
What are the when you tell the patient surgery versus radiotherapy, what are the advantages of both or disadvantages of both? You will tell the patient.
Uh, I would like to tell the patient that if patient undergoes surgical intervention, that will gives a local cancer control. Um, of course, and even if patient requires a salvage treatment after the radical prostatectomy, that will be easy. After radical prostatectomy, staging will be easy. But for radiotherapy, the salvage treatment will be difficult. The patient will have the more complications as compared to radical prostatectomy.
Is it so? You ask a radiologist, he will never agree on it. That's fine. You are right. Okay. And how do you tackle the specimen once you take out? How do you do something or pathologist? What does the pathologist do with that specimen? Any idea?
Sir, pathologist will do the parasagittal section, sir, at the apex, mid, and the base, and uh, in formalin based specimen. Uh,
They also ink the specimen. They
yeah,
apply the over the ink.
I think it basically it is done for margin positivity.
Margin.
What is margin positivity?
hello, sir.
What is margin positivity? Is there any criteria for margin positivity?
Yeah, sir. If there are, if it is a focal and non-focal, if it is a uh, less than 1 mm is like more than 1 mm, then it is a positive margin, sir. in CA, if malignancy involving more than 1 mm of margin, then that is a positive margin.
Yes, reaching up to margin for certain area. So that exact number I don't remember, but you should know it for the writing and on the examination, right? Okay, so I mean, for localized prostate cancer, it is as simple as this. Basically, history taking and all that. Now, regarding PSA, do you know any other markers nowadays?
Yeah, sir.
Yes, suppose this patient had suspicious DRE, PSA was 5, then what you would have done?
Yeah, sir. Other marker like free PSA we can use, or prostate health index, Progensa test is there, 4K test, or a confirmed DX. But only Progensa and prostate health index, these are FDA approved, sir. Other are not approved.
What is
Hello,
PCA? What is PCA?
PCA3. So that is prostate cancer antigen, sir.
Is here
What is the specimen? I mean, what sample you take for that?
urinary
Urine, sir.
urine CA3.
Okay. Any role in this particular case, because the PSA is little high, Gleason score is high. Any role of genomics in these kind of cases? And what is the role of genomic testing, genetic testing?
Uh,
There's a lot of news coming up, in genetics of CA prostate, so that you can see how the disease is going to behave. Any idea?
There's a TMP RSS ERG fusion. And there is a
Any test now? There are few tests commercially available. I don't think they are available in India. Some I don't know, Prolaris, and I mean there are 4 or 5 of them. They have come.
Oncotype DX.
Yeah. So do you advise them? Suppose you have it in India also. Will you advise them?
No, sir.
Why not?
this is a unfavorable intermediate category, so it will not require that. So such test is only when the DRE is negative and gray zone PSA, especially for between 4 to 10.
It is not that. Basically, it is done on the specimen you take after, I mean, either TURP specimen or radical prostate specimen. You do it on the specimen. So, patient is already a known case of CA prostate. It is basically to prognosticate, to know whether it is going to progress fast or not. The temperature fusion, it is there, then it is sign of rapid progression or early recurrence. Is there, I mean, but normally, so far its clinical utility is not proven. It is not going to change the line of treatment. So that is why the routine use of genetic testing is still not there. You can ask questions. Anything you want to know, any confusion?
Sir, after radical cystectomy is what is the early salvage and there is a regular salvage, adjuvant early salvage and salvage radiotherapy. About there was a confusion about that.
Yeah, actually,
at what level we give the?
That means your specimen. Are you asking that? Suppose you do radical prostatectomy and it shows margin positivity, or it shows early invasion of seminal. This is what you are asking?
Yes, that was the adjuvant radiation therapy. But at what level we give we give RT? That's called the early salvage. And what level of the PSA? That called the regular salvage therapy.
Again, I mean, Americans, they give you a lot of confusing terms, salvage and whatnot. You see, the thing is, once you do the radical surgery and your biopsy shows that there was invasion or involvement of seminal and or the margin positivity. You see, all depends on the Gleason score. It's very important. Suppose your specimen comes out to be there is upstaging. Suppose it is 9 or 8, then you can discuss with the patient for an early radiation, right? Adjuvant. You call it adjuvant radiation. I don't know. After surgery, what do you mean by salvage radiation? These are again terms which confuse me. Important thing is the decision of doing radiotherapy after radical prostatectomy. If this is your question,
Hmm.
delay it. Don't do it if margin is positive. Don't do it if it is if there is involvement of seminal also. Consider that seminal were involved, but they have been removed. You keep following with the PSA.
Yes.
Unless PSA rises, don't do anything.
Hmm.
Because radiotherapy is not a simple thing, and they don't do a partial radiotherapy. They will do the full course. When there is an involvement of seminal or there is a local recurrence, they don't do a half kind of radiation. So be aware that when you advise the patient for additional radiation or adjuvant radiation therapy, he is going to get a full dose and going to get a lot of complications. So you don't irradiate prostatic bed so easily. So during follow-up, when there is biochemical recurrence, you don't find anywhere the disease anywhere else, then of course you go for radiation. Anything which was important and we are missing. Yeah, Tanuj?
Sir, in exam, what should we tell, sir, for targeted biopsy or systematic biopsy? Because like we are doing only trust systemic biopsy. So as per EAU guidelines, if PIRATS is more than 3, we should go for targeted biopsy also. So
You
in exam, what should we tell? Like they will confusion.
see, targeted can be done primarily by only MR fusion. Okay, targeted biopsy. See, trust biopsy, again, you should understand. I mean, you can write whatever way in the examination, you can explain yourself. But important thing is trust guided biopsy is not a targeted biopsy. It is basically a geographical biopsy. You cover the whole, see, in midline 3, lateral 3, on the other side 3. So you make it 12 course. Okay. So this is the standard way. MRI tells you that there is a lesion in this particular area, you take more biopsy because on ultrasound you can hardly see the lesion. On ultrasound, if you see a lesion, it doesn't have to be the malignant area. You see, if you see it is hypoechoic, it may not be. And if you go for, if you ignore one hyperechoic area, there may be a cancer there. So, trust biopsy is largely a geographical biopsy. With the help of MRI, you know where the area is, you call that targeted biopsy, but there is still a guesswork. Unless you superimpose the MRI picture with TRUS, you don't call it targeted biopsy. So, tell me, this biopsy was MRI guided biopsy or what? This
Yeah, sir,
biopsy,
like targeted.
MR fusion biopsy or normal TRUS biopsy?
Uh, Mostly MR fusion, sir. No idea actually. Exact.
No, because only if it is MR fusion, you can say that you targeted the suspected area also. So you call it trust biopsy. You see, not everybody is doing MR fusion biopsy. If you are doing trust biopsy, just trust biopsy. If it is targeted biopsy, it is an MR fusion biopsy.
Okay, sir.
If you have any other question, come up. Anybody actually. But this is a good question.
If there is a palpable nodule on DRE, then what to ask first? Directly go for MPMRI, or can we go directly on the trust guided biopsy?
Yes, actually, it's a very good question. In practice, also we do this. When you have a real palpable disease, you don't need MRI because now you know there is a disease. So there are two different reasons you are doing MRI and biopsy. Biopsy is for diagnosis. MRI is also for staging, loco-regional staging. When you do this, you do MRI, you finally have to go for a bone scan. So when there is a patient who is having a frankly malignant prostate, you take biopsy. And for staging, you can go for even a PET-CT. Although PET-CT may not be in the guidelines right now. Is it there? I don't know. I didn't read the guideline, but PET-CT doesn't, PET-CT is not included easily in guidelines. And maybe next time it will be included. But that is a good idea. Take biopsy, confirm the diagnosis, and for staging, just go for PET-CT. It will tell you the bone and everywhere, nodes and all. Because if you consider the cost part, cost of MRI and cost of bone scan is quite close to PET-CT. Okay. So your question is, if there is a frankly malignant prostate, go for biopsy straight. Once biopsy is positive, go for PET-CT, if that is your idea. If you don't have PET-CT, then you go for MRI because you still need a loco-regional staging. There are places where PET-CT is not there. Then you need MRI for loco-regional, means nodal staging. And of course, then for bones, you go for bone scan. Does it answer or not? Is it clear?
Yes, sir.
If there is any confusion, ask me.
Yes.
So in AAU guidelines, they have specifically mentioned, sir, do MP-MRI before biopsy, like
Yeah.
biopsy new patient, like guidelines, strong recommendation.
You should remember. You see, the patient in US and patient in India are absolutely different. They are doing biopsy at PSA 2.5. They hardly have any patient who have palpable disease, right? So they are right. When see a patient comes to your OPD, he comes with PSA in suppose there is a black man comes to OPD with PSA of 3, they suspect very highly. But rectally it will not be palpable. So what are you going to do? You are not going to do biopsy first. You are not going to do PSMA PET-CT first. So only thing which remains is MRI. They are right there, but you should always think in your scenario also. Because now our case scenario was that a palpable disease. So we are not looking for tumor. It is there. It is staring at us. What is left is staging. So this approach in our condition is perfect. That you do biopsy and go for staging, just one investigation for staging. This is, you can say, improvised version of theory. You can always improvise the guidelines and all that, depending on your own patient. Huh? Then you are not wrong. And this is very important because they in US and Europe, they don't have a palpable disease usually.
Yes, sir.
Yeah. That is why all come up. PSA, free PSA, PSA density, velocity, and all that. Because they are not having a frankly malignant prostate.
Yes, sir.
और बोलो क्या मैंने जान तो जैसे what I have left out is lot of studies you must have read, you know, what PSA is justified or not, the part in tables and all that, you know. I mean, they are all theory, so that's why I didn't include in the class. I mean, more like a practical approach. There are so many other things just to describe, but more or less they are theory. We call it off. Okay.